Welcome to the award-winning Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our mission is to educate, advocate, and inspire women in healthcare to lift as they rise. Each episode brings you voices of leaders who are breaking barriers and leading the way in advancing women's health. Join our global community of listeners as we hear from her. Ready to be part of the movement? Let's dive in.
Welcome to today's episode of Hear From Her. I am Sarah Thorpe, your host. What makes this conversation particularly meaningful is that we will explore not only scientific innovation in respiratory care, but also the leadership journeys of two women shaping the future of this field. It's a dialogue about impact on patients, on systems, on the next generation of women in respiratory medicine and biotech. Today, we're joined by two leaders who have shaped respiratory health in different ways, yet complementary ways. I would like to welcome our two guests, Dr. Doreen Addrizzo-Harris, Professor of Medicine, Division of Pulmonary Critical Care, Sleep Medicine at NYU Grossman School of Medicine, a national voice and driving force in bronchiectasis and NTM care, whose career has shaped by mentorship, clinical innovation, and a deep commitment to her patients. Welcome.
Thank you.
And Dr. Martina Flammer, Chief Medical Officer at Insmed, a biotech and medical leader who has spent years helping translate science into meaningful change for patients and clinicians. Together, they bring a really unique blend of perspectives on leadership, innovation, and the experiences of women living with chronic respiratory disease. Before we talk about systems, science, and innovation, I want to understand that spark. Every leadership journey starts somewhere. So, can you each share your path into respiratory health? What pulled you into this field and what made you stay? Dr. Addrizzo-Harris?
Sure. As many people know who know me and my history, I had a dad who was a pulmonologist and my first mentor. My grandfather was also an internist, so a long history of physicians. But I really, of four children, was the only one who went into medicine because I spent most of my time with him when he was rounding, when he was in clinic. And I just loved, and not so much even the science, I loved the connection to the patient. And that's what really drew me in the beginning when I was young and very excited to have great mentors along the way through med school and through my training in New York City at Bellevue and NYU. And I think that's what's kept me in this on a positive path is a lot of the people that have been my teachers since the beginning.
I love that. And how about for you, Dr. Flammer?
Yeah, I didn't really take a straight path into pulmonary medicine or biotech for that matter. Uh, Also, my early role model and I think mentor from early on was my mom. She was not a physician, and I don't come from a line of physicians, but actually a line of business people and artists. So you wouldn't necessarily think medicine is the next or what comes to mind. Uh, what what brought me to medicine is my mom's strong encouragement to go after what is really my passion and where I got fulfillment. And I enjoyed that early on from interactions with a cousin of mine who actually was a nurse. But that was my first exposure into medicine. And that fulfillment of being there for patients, I think for people in need where you can make an immediate impact was very satisfying early on. And it just led me down the path of medicine will be my future home. And after years of clinical practice, the other area that was very interesting to me was always different health systems and how patients actually go through a health system. How do they get their care? And that eventually made me pivot from the clinical day-to-day practice to research, and within research to the pharma and biotech industry that allowed me to think about the patient, but also what new treatments, what new innovations can we bring to patients? And always in that context of how do patients flow through a healthcare system? How do they get access to these innovations? And in the end, I think that's where we just want to have the biggest impact is of what we can bring to patients. And that was the start, and that's where I are today.
I love that for both of you, it's the patient who is the anchor, that connective thread driving you, motivating you. So, as you think back to those early years, what are some lessons or experiences that really stick with you today?
So, as I said, connecting with the patient was really something I saw that my dad did very well. And I always loved that, he always knew something about them unrelated to their medical illness that kind of kept them connected, whether it was a hobby they were doing or something about their children. And so they really connected as people and often as friends. And, he was just as passionate about that part of them as he was about the disease, the pulmonary disease they might have. And so I think he was a very good listener, and he would always tell me, as one of my firm chief during med school told me, you can find out so much about the patient and about the disease they have if you just spend time listening to them and doing a good physical exam. And I still think to this day that is so true and something that so many of our, junior faculty who are so busy and so rushed kind of forget. It's not about all the tests that we're doing sometimes. It's more about the patient story and who they are. And sometimes that leads you to the right diagnosis over, many of the tests that we do.
Yeah.
It's such an important point. Listening isn't passive, it's that diagnostic tool. And when we slow down and hear that experience, we can uncover a lot of nuances there.
Yeah, I think listening is listening is probably the first and most important tool from a medical practice perspective, but also I think from the leadership perspective. Because when you know how to listen, you understand what people are telling you, sometimes not only in words, but it's the communication in how do they behave, what's important to them. So the diagnostic tool in medicine becomes also a diagnostic tool and an important skill. I think as we become leaders or became leaders through our journey. And and that also helps you finding your own voice and then use your voice, I think, um, in the right place at the right time, whether that is vis-a-vis a patient or it is as a leader, as younger faculty members or even medical students come along. So you teach them about the importance of listening, but also about finding their voice and not being afraid of communicating what their perspectives are. So as you advance, I think those are the pieces that we learn on the leadership side that we lift up others. And it can be patients that we lift up, or it can be, students or just younger people that we hope to influence have um, beneficially along the way.
Listening creates an intentional pause, both in leadership as well as when you're interacting with patients to reflect and then respond actively to what's being presented to you. And so that's a nice segue here in terms of leadership in the space. And so, hearing about kind of your early experiences and learnings makes me think about the environments you're navigating at that time as you were coming up in your career. You both rose in spaces where female leadership was not the norm, especially in pulmonary medicine. So, what did it feel like to navigate your early career with so few women to look up to as role models or share a seat with at the table?
Well, from my perspective, again, going back to my dad, he had first three girls and he treated none of us any differently than he treated the boys. So he taught us how to hunt, how to fish, how to ride horses, how to cut down trees with chainsaws. I never really felt like I was any different than the men that I was working with. And back then in critical care, there were very few women in the ICU, especially in leadership roles. I probably would say none. And so I kind of probably didn't notice it as much as many others may have, but I always found it to be a challenge. Just wanted to be as good as everybody else and focus on what was important. And as I grew in my career and I did look up to those women leaders. Particularly for me at Bellevue Hospital, there were several women leaders. One of them had been an ATS president, Ann Davis, back in the early days, and she was one of the senior faculty here. So I was lucky to have a few women working here. Dr. Roberta Goldring, again, who is a professor emeritus now, was running our uh, PFT lab, and she was with the team that won the Nobel Prize in medicine back in the 1950s. So I was with some big giants, but I understand that when I looked around at my peers who I was working with in the ICU, yeah, I was the only female. And so I think it really takes just take being positive about the challenge, not being upset about it, just working hard and working together and making sure that you were respected and valued for, the work that you were doing. And I think I was lucky to be in that kind of environment.
Yeah, let me just add, isn't what Doreen said is so important. You have to you have to be lucky sometimes to find the right people or to have the people around you, but you can also seek them out. And I first took looking that up earlier when I was thinking about that interview when maybe Doreen and I started out, absolutely you felt like we are the novelty. Um, and especially in critical care fields in pulmonary medicine, I think even more so. But I can tell you, I looked it up today, and even today, about 30% are women, and over 60% obviously are men. So it is we've come a long way, but we can still go further. So we we have an opportunity to bring more, I think, women voices in, and that is in the clinical practice side. And I'm also looking at it from the research, so the biotech in leader side. There's even, I want to say, less a shift towards women. It is in the entry level and mid management, but in very senior management positions, it's still less than 20%, 25% at the most. And I think that's where we need to see that shift happen. But it starts early on. It starts in finding those mentors, giving other women the confidence of what they can do. And I think women have come a long way also in partnering with each other and supporting each other. And that doesn't hasn't just happened over time because time passed us by. It's because we've demonstrated continuously that competency, that resilience, that growth in skill set. Um, and I think for women, many times we had to demonstrate that above and beyond because it wasn't just an assumption that you would have it. You had to show it over and over again. And that has shifted, I think, but there is still a long way to go. But for new colleagues, women who enter this field, I think having good partners and seeking out other women who can support you sometimes and give you the confidence when you may feel you need a helping hand to strengthen your back.
Yeah, very important, Martina, too, that if you don't see what you need around you at your own institution or in your own company, look outside. Having external mentors sometimes can even be better or add something. They've got a different viewpoint. They may be more open and able to say things that are actually true because they're outside of your institution. So, trying to find those people as well it is really helpful and has helped me as well along the way. Because I agree with Martina in leadership positions still we are nowhere near where we need to be, across the country. And so I think that's still a challenge for us.
Well, it's encouraging to hear that it is changing, but that there's still growth there. And I think there is a lot of practical advice that you have offered just now. I'm curious though, how did you know that you found that space where you could truly feel that you could grow? What did that feel like when you found that moment and that home for you in your career?
I was very lucky to land in a very unique, wonderful place. But I'm sure there are many people who don't start out in the best spot. And so you have to have the courage to reach out to people who can help advise you and to make a change. Because if you're not feeling like you can do those things and get up in the morning and really want to be at work and be with your colleagues, then you are at the wrong place.
Yeah. I think you will know that you're in the right place when it allows you to be fulfilled in your work. Your voice is heard. You feel you have the impact, whether that is on patients or it's on research. And when you leave at the end of the day or the end of the night, whatever your shift may allow, you have a sense of fulfillment that you've made an impact, and you have to be ambitious, not being afraid to step out of an environment that doesn't allow you to grow, or where you don't feel you have a voice, or you can't make an impact, or your impact is not recognized. I think that's where you have to be honest to yourself and say, is this what I really want to do? And then make a change. And often I think we can encourage, especially women, be ambitious. Be ambitious. I mean, people don't have to they assign you a place, but if that's not the place where you want to be, then just leave it because there is more opportunity than you would think. But you do have to, you do have to open your eyes and be willing to make those changes because it also requires you to, you know, basically say, well, that is not my place. I will move on. And that's often a very hard decision.
Yeah, I think that takes a lot of courage. And I think that really matters for our listeners because so many of our careers don't unfold exactly as we've planned. And growth often looks like pivoting, asking those bigger questions, or redefining what our contribution looks like. So I appreciate you sharing that perspective. Um, so with leadership, leadership is shaping culture, but it also shapes care. It influences how we define unmet needs and what outcomes we are prioritizing in research and how our systems are designed. And when certain voices have been underrepresented, I think it's worth exploring how that has shaped the way we look at women's respiratory diseases. So I'd like to shift the conversation now to women living with chronic respiratory diseases and how leadership is shaping that perspective. So, what is that day to day lived burden that you hear from women with chronic respiratory conditions?
So it's a big burden. And I think that we haven't, as a community in the past, listened as much as we should have, right? Patients live with a day to day stress or anxiety. First of all, wondering how well they're going to be and if they can get through the day, or worrying about the next time they're going to be sick, particularly in our specialty with bronchiectasis and exacerbations. They're always so fearful about when their next exacerbation and illness is going to happen on top of their chronic condition, and then trying to find the time in the day to do all the things they have to do between their medication regimen and their airway clearance regimen and getting good nutrition and getting good sleep and still having all the burdens of what most women have of dealing with a family, whether it's elderly, whether it's parents, whether it's children, whether it's their significant others. Right? And trying to put that all into one day and figure out how they're going to get through it, especially when at baseline they may not be feeling very well. Um, yeah, I think it's very difficult for women to ask for help and put themselves first. There's probably something genetic to that. We're mothers, many of us, or aunts, or always caring for someone else, so that nurturing aspect, that we forget that we have to care for ourselves first so that we can take care of everybody else that we want to take care of. So that I think it's partially our role as the provider, as the physician, to help them see how important that piece is. Not only the things that we tell them they have to do, which are related to their illness, but so much else. Reducing their anxiety. Some of them may have depression, getting help for that. I mean, there are just so many things that you can do to try and help patients have a better quality of life. And I think a lot of that lies now with the physicians, and particularly in this field, the healthcare team that is taking care of patients with, bronchiectasis and for me, non-tuberculous mycobacterial lung disease. So, yeah, there's a lot more to it than when I started out in med school, and nobody talked about any of this stuff. And that was, 40 years ago.
Yeah. At least now, I think, Doreen, is there is already a more attention given to what also is specific for women, right? I mean, especially in respiratory medicine. I mean, think about when we think about, breathing, this is the most fundamental. If we can't breathe, breathlessness, that impacts you every step of the day. From getting up in the morning until you're trying to get ready, that is such a heavy burden that there isn't the time where you may experience, it's there, my pain is gone away, or I'm taking a painkiller, and therefore I don't feel it. Breathlessness or some of those symptoms can be so burdensome, and they are always there. And often in respiratory diseases, bronchiectasis, so women may experience some of these symptoms even more than men. Maybe their pulmonary function is similar, but they experience those symptoms more severely. And I think with women in as pulmonologists and in this field, we sense also better of what may be in the forefront of other women as they experience a disease. How do you diagnose that? There is maybe less bias in assuming that something is just due to anxiety. That has often been an issue, especially in respiratory medicine, where, well, is this really the disease, or is this triggered by anxiety? That was in asthma often the case, but certainly also how long did it take, and still does, until women get to a diagnosis for bronchiectasis. If you don't think about it and there isn't that clinical suspicion, it often takes women longer to get to a diagnosis. Part of it is, yes, it may seek them also longer to take care, but you know it's physicians who often have to inquire with patients, and there's the listening is again part of that. But having you have to think about what women may have as an underlying diagnosis, and be very critical in making sure that you get to that diagnosis. Also, I think in a faster way than maybe it has been done in the past.
So you've both emphasized, from the start of our conversation, the importance of listening, the importance of the patient perspective. And I again hear that thread coming through in terms of accelerating that diagnostic journey for the patient, kind of thinking about life function as a key metric here, in terms of understanding the burden. So patients can teach us far more than sometimes we may expect. So how do we approach that clinically? How does this change how we should be thinking about respiratory conditions like NTM or bronchiectasis?
Well, I think something that we do quite a bit is educate our patients. There is so much that we do to educate them, from seminars to pamphlets to new advocacy groups and websites. It's been phenomenal. And I think that empowers them. That makes them part of the team, because they then become a more active part of the healthcare team for themselves. Many of my patients will bring in new articles or new things that I may not have even heard yet, or they've attended a webinar that, and they talk about a new airway clearance device. I love it. They're educating us, and they're empowering themselves. And you know, working with each other to find ways that, help take care of, fix the disease. So I do think, um, spending a lot of time just telling patients who may have shortness of breath or have a cough, what they should be asking their doctor. First of all, don't be afraid to ask questions to your doctor. And if you're not getting an answer, ask for another doctor or a different doctor. But empowering patients to say, you know, okay, I understood what you said, but I still have three more questions. Why is the cough not going away? Or why am I coming in every, three times a year for antibiotics? So I think that's also important. And we try to put out literature there for questions that they should feel comfortable asking their patients if they have a chronic cough, if they have persistent shortness of breath. So, yeah, empowering the patient is extremely important.
Yeah. And I think we've seen over the last 10, 15 years, maybe longer, Doreen, but it feels to me that that's when we've really seen this rise of the informed patients, patients getting that confidence of becoming a partner in their healthcare decision making. From if you really think back again, maybe when we started, it was much more a passive situation that this was physician driven. Today, it's much more a partnership. And I want to always think that women took actually had a big role in that on their ability and openness on partnering the in a more collaborative way with patients, way of actually being interested what is important for this particular patient in front of me, but also of what do patients care about uh, in their clinical care. And they've also become partners in research, I have to say. If I were going to think back of my first very early clinical trials, I don't think 25 years or 30 years ago we were asking patients to give us intact feedback on a protocol. And now we couldn't think not to do that, right? They have become research partners. Um, whether it's a new treatment, we want to know what's impactful for a patient. What are the symptoms they care about? What is it that the burden of the disease or the quality of life is important to them? Not only what would we like to do from the research side, but what's important to them, and see can we design actually new treatments and identify them that specifically look at what's important for patients. So such a big shift over the last 10, 15 years. And we've learned from those in the clinical care, but also in research of how do we go about this. New tools were developed on, a lot of the patient reported outcomes. That's what they're called. It's important outcomes for the patient. While it is always important that we have clinical evidence and there may be an objective measurement and like a lung function, yes, of course, we want to know that. But the patient doesn't necessarily care about the number of the lung function. They care if they can walk up a flight of stairs without having to stop 5 times. So that's where we've truly seen that change, and it's been an enriching work experience. Absolutely, I think for us.
I think that's such an important point. Partnering with the patient, starting at that root in terms of how you're designing the clinical trials, as that's going to shape the whole system of care and outcome for the patient at the end of the day. So that shift from treating patients to partnering with them, as you said, is really meaningful. So how do we keep that momentum going at a systems level? Like comprehensive care networks, best practice models. How is that transforming how healthcare is delivered at the system?
So I thank you for that question. So what we have started to do is to do this on a national level, and many countries are following the same. We've developed a care center network of care centers that focus on patients with bronchiectasis and non-tuberculous mycobacterial lung disease through the Bronchiectasis and NTM Association, a newly formed association as of January 2025, an arm of the COPD Foundation. This association has now set up 59 centers across the United States And I am lucky enough to be the chair of our steering committee and the clinical care arm. And I work with two other phenomenal physicians, Dr. Chuck Daly, who is in charge of the research arm, and Dr. Tim Axmet, who's in charge of patient education and advocacy. And we are building healthcare teams at each of these 59 sites. Hope is that we will have a center in every state and more, and in a number of underserved areas. We may have large cities that need more than one center. And so, hoping to have that increase by 2027. And into each of these sites, we are building the healthcare teams with a focus on patient education in all aspects of care. And again, empowering the patient to be a member on the team. We're building a phenomenal website with the organization. We are doing live symposiums, virtual symposiums, you name it. And not just through our association and the care center networks, but it's becoming infectious. The community of physicians, of patients, of caregivers, of industry leaders and industry teams, you name it, that are in the space of bronchiectasis and NTM has just grown exponentially. It's a phenomenal community working together, all of it to benefit the patient and research in this space, the advancing of science in this space. So it's a great place to be. But as you pointed out, it's great to be able to do it on a individual patient level, a local level, but it really means something when we're starting to do it on a national level and hopefully international level. That this will hopefully really impact this disease, so that we can really change the trajectory of the progressive nature of so much of this disease in some of our patients.
Yeah, and maybe that could even be a great model for other diseases, right? If you are able to influence and build almost like a multidisciplinary educational network on around a one disease, and it allows patients to be aware of it, but also new pulmonologists to that particular disease area. It's not something not necessarily NTM or bronchiectasis are not necessarily something a pulmonologist who is not working in an academic center or a larger clinic sees every day. So it's really important also for them. How do I think about a diagnosis? How do I think about a differential diagnosis? And if and the community or center or care networks that are built around the patient also enable that this care is delivered at the same high quality. It is not only centered around the academic centers, but it enables you to do that even if you live in a more remote place or if you don't necessarily have access to a pulmonologist all the time. You know where to go and you will receive the same high level of care that you may get at NYU. And I think that is so valuable for 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 driving the knowledge on patients, but also how care is delivered and enabling the access to patients. In the end, everything we try to do, new insights, research, treatments, they only really have value if we can get it to the patient. If we can't get them to the patient at the best level possible, then we've not really reached our goal. So that is such an important effort, and in care networks, they can be so powerful, and they can be an example for other diseases. So people can learn from just this example.
59 sites, that's huge. Congratulations. That's an amazing milestone. And, I'm already hearing our next interview where we're talking about the success of this, best practices, and how to build out care networks across disease states. I mean, to your point, it's such a powerful model in terms of democratizing healthcare and enabling access. So such a positive note for us to shift and transition to the interview as we close out here. Your insights about patients as the co-architects of care really underscore how much the field is being shaped by relationships and challenging how we deliver care based on those relationships, whether it's from patients, mentors, your team, the community that you're serving. So, as we close, what's one small habit or mindset that has shifted you and driven you as you think about the impact in your career?
So I have to say I have two. My first is optimism. There's a lot we could complain about every day, but there's a lot of good in every day as well. So I always see the glass as half full. And I try as best I can, even for the sickest patient, to have them try and see what we're trying to do for them that way. But that does not mean that for the things that aren't going well, I stop there and say, okay, I never accept someone saying, no, you cannot do that, or no, we cannot fix that. There is always a way when there's a will and when there's a team of people working at it. I'm sure there are cases where you can tell me no is no, but I never like to believe that. I always feel like there is always a way. You may not get 100% of what you want, but if you don't try, you'll get 0%. So there's always a way to get something. And I do think that that coupled with being optimistic and having hope really helps me get through the day. And I like to try and share that with my team and my patients, even when we have the craziest of days.
Yeah, you absolutely have to go for it. I think that has to be the habit. You have to go for it. And sometimes you do it for yourself, but in most of your day, will you do it for your patients? You do it for what your goal is with the individual patient, or it is a larger overall goal of bringing something, a new treatment to market, or and I think you have to go for that. You owe it to yourself. And from time to time, you also have to look and pressure test. Am I still on track? Is this still what I want to do? And am I still making that impact? And I think that periodic self reflection helps you to stay on track. And it also helps your patients. Are you really doing what's in the best interest of your patient? Um, and I think that all has to be front and center.
Very good point.
And when we think about the future of respiratory care, especially for women, what is giving you the most hope?
Well, I mean, there's just so much new innovation happening at this time, not just in bronchiectasis, but in so many different areas of chronic pulmonary disease. And we're starting to find overlaps between diseases where sometimes the one medication can help with two different diseases. So it's just a very exciting time that the importance of respiratory health there was always cardiac health. I grew up that was the only thing that was important and only important in men because nobody ever thought women were gonna have any problems with cardiac disease. So, right? And so now the shift has, pulmonary diseases have really come around and respiratory health is so important. I mean, COVID also helped, emphasize that and, infection control and all of that because it hit a lot of people really, at home, et cetera. And so I think that's what we take away from this, that this is a new era for respiratory health, unbelievably innovative with a really rich community of people that are passionate about finding new ways to deal with a lot of these respiratory illnesses.
Yeah, I think I agree. The That was the silver lining maybe of a pandemic like COVID that brought it back to everybody how fundamental um respiratory health is. If you do not breathe, you don't live. And there is just no alternative. So it's I think that was a gave a real lift into what what do we need to do, whether it's in the infectious disease side where we need new tools to ensure that we can actually treat respiratory diseases who may not have any options in the anymore, and also how do we bring new mechanism of actions into respiratory medicine. And I think that encourages also an influx of young physicians and medical students to have the interest in respiratory medicines. Yes, Doreen was speaking about cardiology, and everybody wanted to be in cardiology 30 years ago. That I do think we see a shift there, and that is very encouraging and hopeful. The options today for patients are clearly much better than it was years ago, but there is so much more that we have to discover. And also, the most encouraging part at the end for us will be, how do we get this to patients as fast as possible? Often it takes still too long to bring it to the patient, but with the focus on respiratory medicine now, uh, that's probably the most encouraging over the last couple of years.
Well, as we close today's episode of Hear From Her, I just want to thank you both for showing us how optimism is not naive, it's strategic. We should go for it. We should continue to listen to our patients. It's that belief that with impact, we can design better systems, create smarter therapies, and lead in ways that widen the opportunity in healthcare for our patients and for ourselves professionally. So thank you for your time, and thank you for listening in to today's episode of Hear From Her.
Thank you for having us.
To our listeners around the world, thanks for joining us today. Tune in as we continue our journey to amplify the voices of women leaders in healthcare. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next time, remember to lift as you rise.